Ladies and gentlemen, good morning. I would like to introduce myself. I'm Dr. Ahmed Jan. I'm from Saudi Arabia. I joined Dr. Lakdawala for training in the advanced laparoscopic surgery and bariatric surgery. Welcome to ACMOMS VI, which is held here in the beautiful historical place of Falaknuma Palace. And I wish all of you to enjoy your stay here. Our theme in this Congress will be controversy in metabolic surgery. I would like to introduce Dr. Lakdawala is one of the leading bariatric surgeons in Asia Pacific region. ACMOMS is his brainchild. Previous 5 ACMOMS have been great success and have addressed diverse themes in bariatric and metabolic surgery. May I present Dr. Lakdawala for his welcome address. Please, Dr. Lakdawala.
Thank you, Ahmed, and so welcome to the 6th ACMOMS. Let me just load this. Yeah. As everyone, as they say in Hyderabad, Adab, and Adab means welcome in the local dialect. So in case you greet people and people say Adab, that's just their welcoming of you. So, like I said, it's great to have all of you here. I'll just carry you through. Some of you all have been with us through almost all 6 editions of these ACMOM, and some of you all are joining us for the first time, maybe the second time. I'll just give you a little brief of what ACMOMS actually stands for. So the whole idea of starting ACMOMS was way back when Asia was not such a big force to reckon with in bariatrics, and we had only VJ's work to deal with, and some of us were small little babies to start with. So we started, and we took some few baby steps with the first ACMOMS towards our big dreams of establishing Asia as the biggest pediatric, and one of the biggest pediatrics after the US and South America. We thought we'd at least catch up with our big brothers, the Australians, to try and make Asia Pacific a little bigger. So at the core of ACMOMS lies that belief. And like Harry says, this is a saying that I wrote down, and it's a belief to tread a path undiscovered by the others rather than follow the norm. So that's what I believe in life, and that's what I stand for. So I always take the unconventional, maybe sometimes good, maybe sometimes I develop enemies along the way. But that's how ACMOM started, and that's how we progress. So you'll see the core, the cream of Asian pediatrics here, and some of the best international names to help us along this way. So the goal, again, like I said, was to set culturally, geographically, and genetically relevant standards for the management of obesity and metabolic syndrome, and which was just rearing its ugly head at that point of time. When we first met for ACMOMS, it was all about setting guidelines, because that was one of our first meeting, and that was to set and identify the usefulness of BMI as a principal criteria, because we never believed that BMI really worked in the region. And the guidelines that were set were way back, the NIH guidelines, which were set in 1991, which were not even relevant even for America today, but we were following those guidelines in Asia. So we believed waist was more relevant because of abdominal obesity and abdominal fat, and we believed that visceral obesity was more relevant than other subcutaneous obesity. And therefore, we sat down to make this. This was the first ACMOMS invite that we sent out to most of you here. We had around 60-odd people at that meeting, and that's how the journey started. This is the core group, and you can see a very young-looking Harry. I didn't have so many white hair at that point of time. And after Kasama still looks the fittest, as always. But that's how the journey started. So this resulted in us publishing the first report of its kind in the region. So this was first published about setting guidelines for the Asia Pacific region. And this followed a host of various reform guidelines that we soon had in the region. So we had the first Asia Pacific Bariatric Surgery Summit held by Dr. Vijay Lee, and these were some of the relevant guidelines. The idea was to drop the BMI points for the Asians, at least by either 3 or 2.5 BMI points, and all of us agreed at that point of time that we need to, all of us agreed that we need to give more relevance to type 2 diabetes in the scenario. So in 2010, again, we met in Taipei for the ADSS summit, and again modified these guidelines. So all worked around what we believe would be the most relevant guidelines for the region. More and more guidelines have started coming in, and we started looking at age, and every guideline got better than the previous one that we set. Then Kusama just wrote this paper up of the IFSO APC guidelines. So all culminating, and these are the most current and relevant guidelines for the region, and it's been published with most of us sitting out over here would be a part of this paper as well. So these are the ACMOMs. So the idea was to show most of you guys and most foreigners different beautiful parts of India. We believe India is a beautiful country, and we can show you different parts, but culturally so different from where we stand. So ACMOMS I was in Trivandrum. Very beautiful and serene down south of India. Then we went up to the northwest, that was Jodhpur, little Rajasthan with the royal palaces and various other things. Then we went to the sunny Goa. So the journey moved from one part of India to the other. The idea was to have a very good location so that you could enjoy the place as well. So this was our second ACMOMS, and it was, ACMOMS was never done as a general meeting on bariatrics. It was always done with one point and agenda in mind. Second one we had with sleeve gastrectomy, because it was the most relevant topic at that point of time. And sleeve gastrectomy 5 years back was the emerging trend in the region. This is the third meeting. This is the second meeting. And we had, at that point of time also, a lot of societies started to endorse us for the relevance of this. This is the third and fourth meetings. The fourth meeting was on complications. So we moved from sleeve gastrectomy to revisional surgery to eventually to complications in pediatrics. The idea was to discuss threadbare the various aspects of the complications that would be. Again, we had enough of endorsements even continuing through all these meetings. And this was the last meeting that we had in Delhi, which was again back to metabolic surgery. And we had with us a very good team of endocrinologists, some of the most respected and written about names in literature, and some of the best diabetologists from the region who were part of this meeting. The idea was to make them more relevant about what is the current status of metabolic and diabetes surgery in the region and in the world. We believed that without publications, we couldn't stand on our feet, and so soon started getting more and more. And Vijay is the leader in terms of publication in the region, and he's published a lot, and therefore I didn't have too much space to put in all his publications here. But I think I just put in a few that we started doing in our series. We've got an ATF journal we started publishing there as well to promote it. These are some of our own publications. We wrote about nutrition and various other things. Then this is a paper which published Bariatric Surgery in Asia in the last 5 years from David Lamantos and Asim Shabir's group from Singapore. They assimilated data from whoever was ready to give in the data in the region, and we got that done. Then Vijay and his continuous effort to try and get more and more research into the field, again published this paper. Now we also have the ABC score that is published, which would probably he'll be speaking on, and I won't delve too much into it, about what is the relevant things and when do you operate and when do you not operate. After Ricardo's paper, which is probably the longest standing paper of 6-year results with low BMI gastric bypass, we published this, which are 5-year results with low BMI gastric bypass. So these, I think, are the 2 longest standing papers today in literature. So as you see, the region has started throwing up more and more publications, and we started making a little difference. So much so that when the IDF guidelines were formed, and John and Francesco and the group thought that it would be relevant to include the Asians, because so far the guidelines did not include too many Asians, but Professor Linong Ji from China, myself and Vijay were part of this meeting at IDF. And the good thing that we emerged is, if you see that, we made sure that the Asian voice was heard and the BMI points were dropped even in the IDF consensus, because Asia as a whole, India, the world as a whole cannot be without Asia, because the largest proportion of diabetics probably come from this region. Then we wrote this critique or comment on the IDF, and this was published in the Asian Journal, which is read by most surgeons across the region. We also had the sleeve gastrectomy panel, and this was sponsored by J&J at that point of time, and they included all the regions. So this was done in the US, and Raul read this whole thing, but it included South America, and Armino was a part of that, and included Europe, and Jacques was part of that. And from Asia, they had asked me, and we had called in a few of our colleagues from Asia to be part of this summit. So it had some of the guys who've done the largest number of sleeves in the world, and I believe that in Asia today, we probably will be among the topmost guys to have done sleeves in the world. We also believe that we needed to train people around the region to get better and better results. And we started training fellowships a few years back. And this is the journey of all our fellows that we've had so far in the region. And Aparna today has turned a fellow to an expert in the field. And today she probably is one of the female surgeons, you can say. I'm not trying to be too sexist, but probably the first female surgeon to have done single incision surgery in Asia and probably in the world. And now has got one of the largest series of single incision surgeries. So Amit is our fellow who's just completed 1 year, and our belief is that in the region we can give them hands-on training, and that's the good thing. So they can actually operate, and they can be individual enough to operate after they complete a fellowship from our center. This is, these are all the various international fellows we started getting in. We started getting in people from Malaysia and from Singapore, and now we've just got in somebody from Qatar who's just joining us. So Ahmed, you saw him in the morning, and Hind has just joined us 2 days back as our fellow. We've also needed support of all endorsing societies to make this a relevant meeting. So all along we've had support, and this year I'm very, very thankful to all these regions and for giving us the support to make this a very relevant and important meeting. Of course, you can't have any meeting without our sponsors, and again, I'm very, very thankful to these sponsors for backing us through and through this whole thing. This is ACMOMS today, and I hope you guys really enjoy this meeting. This is our own meeting. It's got some of the best experts in the world, so if you get a consensus out of this, it'll be very relevant, because there's going to be a lot of arguments, there's going to be a lot of debates, because I believe that two intellectuals never agree on one thing. And so we're going to have fun here and discuss various viewpoints. Now, this is all about the academic part, okay? And we really believe the academic part is the strength of all these meetings. But somewhere along the line, we also believe that you all work and no play makes Jack a dull boy. So we believe that there should be some fun also. So we've had our moments of fun. This is Rajasthan, and that's Harry in an Indian outfit, and Vijay. This is how we welcome, and hopefully today evening we will probably give some part of that. We've also had spouses join us through and through this whole meeting. We've had very good looking speakers through these meetings. We've had some intense talks, some sleepy eyes too, because of the time differences. The social programs have always kept up more and more. This is my team, without who, luckily, I can say that I've got a lot of women who are part of my team. And good for me that they've all been picked by my wife, so there's no complaints on that front. So we've had everybody dancing whichever style that they believe is relevant for the region. And some acrobatics too. Because this is just because as surgeons, as laparoscopic surgeons, sometimes we take such various positions that I thought that was relevant, that we show some of this also. So we've had Pilu who's backed us through all the travel arrangements through and through this whole thing, and my very pregnant wife today looked thinner in those days. This is Kasama showing us some of the Japanese steps that he's used to doing. And Harry is the youngest member of this ACMOMS brotherhood and team. And every woman out over here can vouch for that. And finally, I'd like to thank my wife Priyanka, because I think that it's because of her the whole thing of concept of ACMOMS came, and I really must thank you all again for coming here, and I hope you have a great meeting. Thank you so much.
Thanks. Thank you, Dr. Lakdawala. Actually, we are going to start our first session in our meeting. Thanks for Ethicon to sponsoring this session. It's my proud privilege to invite Professor Seigo Kitano, the giant of surgical field from Japan, and the president of the Oita University.
First of all, thank you very much, Muhazao. You gave me a lot of good memory for each of us at the time, each time of the ACMOS meeting, particularly Castle in Jodhpur. Also, I'd like to congratulate you on your very successful development in the field of laparoscopic bariatric surgery, and you also congratulate on the successful meeting here under your leadership. Sorry. Just click on. Coming. Oh, something else. Not yet? I confirm that. Oh yeah? No. No, it's fine. Still there. Still there. Nothing. What? Something else. Oh, we take it already. Online? Yes, this one. There you go. Okay. Okay. Oh, Hanum, back up. You show the backup there. Yeah, we got backup there behind. Ready? You go. Okay. Oh. Okay. Back up here. You are back up there behind. Yes. Yes. I think the problem is the one line. Okay, line. That's the line. Line down. Okay. Thank you. Okay, no problem. Thanks so much. Sorry for that. Thank you, Mr. Chairman, and for your kind introduction also. I'm very pleased to come back to Hyderabad again and to have the opportunity to present my paper in this meeting. My specific topic that I have been asked to cover is bariatric surgery, controversies favorite child. before starting, I have to confess that I really have few experiences in adolescent and pediatric bariatric surgery. So I mainly review the papers to present this team. In Japan, laparoscopic bariatric procedure has been performed since 2000, only just more than 10 years experiences. Until 2010, we have had approximately 70 cases annually, very little, and 152 patients in 2011 and 176 in 2012, as shown here. Now the number has been rapidly increased. The figure shows the percentage of each laparoscopic bariatric procedure in Japan. The most popular procedure is laparoscopic sleeve gastrectomy, which is occupied 57% of the procedure, 101 among 176 in 2012. Until now, we have experiences of a little more than 110 cases of laparoscopic and endoscopic bariatric procedures in my institution, OITA. The number is quite smaller than yours, though. Our main procedure is now laparoscopic sleeve gastrectomy. With regard to the adolescent and the pediatric bariatric surgery, between 2000 and 2012, only 2 of 749 cases, that means 0.3%, were performed in Japan. We experienced one gastric banding case of 19-year-old, and Dr. Kasama here experiences one gastric bypass case of 80-year-old man. Regarding to the adolescent and child obese population in Japan, changes in lifestyle and dietary habits have resulted in an increasing number of the obese population, as shown here, just like Japanese adult obese population. According to the increased weight, Japanese children also suffer from the obesity-related comorbidities, and such as dyslipidemia and hypertension. Now, increasing of adolescent and pediatric obese population has been one of the health problems in Japan. I really expect that the number of adolescent and pediatric bariatric surgery will rapidly increase in Japan in the near future. I would like to start to review the papers. SAGES Guidelines 2009 describe the comments that with pediatric obesity increasing in prevalence and severity, interest in adolescent bariatric surgery is growing now. Roux-en-Y gastric bypass procedure, excellent weight loss in patients younger than 18 years. Also in 2009, members of ACMBS showed, as you know, clinical guidelines of pediatric and adolescent bariatric surgery. They recommended patient criteria, including more than 12 years old, age more than 35 BMI, developed secondary sexual characteristics. They also showed that the recommended procedure was Roux-en-Y gastric bypass because gastric banding had not been approved by FDA for use in adolescent at that time. Australia and New Zealand surgical societies announced that recommendations in 2010. They indicated a patient criterion of 15 years and more than 15 years of age. They recommended laparoscopic adjustable gastric banding because it has good outcomes so far and low complication rate, and is potentially reversible. Last year, ASMBS guideline, based on the best practice update 2009 was published. The patient criteria were almost same as the previous ones, but the recommended procedures were Roux-en-Y, bypass, and adjustable gastric banding. So far, to my knowledge, there has been one prospective randomized trial for adolescent bariatric surgery from Australia. Professor Bryan and Dixon demonstrated that laparoscopic adjustable gastric banding is superior to lifestyle intervention in terms of weight loss and improvement of obesity-related comorbidities after 2-year follow-up. In the United States, the main procedures for obese children and adolescents were laparoscopic Roux-en-Y bypass and adjustable gastric banding. Despite the worsening childhood obesity epidemic, the rate of inpatient bariatric procedures among adolescents has plateaued in 2003 so far. More recently, in the United States, the main procedures include laparoscopic Roux-en-Y bypass, adjustable gastric banding, and sleeve gastrectomy. The trends reveal the increased use of sleeve gastrectomy and decreased use of gastric banding. A recent paper of laparoscopic sleeve gastrectomy from Saudi Arabia showed the good outcome of weight loss and comorbidities in obese children and adolescents. A recent meta-analysis concluded that bariatric surgery leads to significant short and weight loss in obese children and adolescents. But however, the risks of complications are not well defined yet. Long-term, prospectively designed studies are needed to firmly establish the harms and benefits of bariatric surgery in children and adolescents. Finally, I listed issues of pediatric and adolescent bariatric surgery. Most of you know, the problems include their immature characteristics, informed consent for children, long-term counseling and care, quite difficult sometimes, risk of long-term complications while we operate on the younger age, adequate weight loss, cut-off patient criterion. How can I count the average weight? Optimal weight loss procedure, which one is better? And who is operator? I think the most important factor is the operator. We have to do our best to train ourselves. Our problems, I think the problems is a lot I have shown there. I love to show our case, only one case, in 19 years old. He was 19 years old, male. His initial BMI was 76.8 because he was a teenager, and laparoscopic adjusted gastric banding is potentially reversible. We performed gastric banding after inpatient diet, treatment, and endoscopic intragastric balloon placement. So far, we have to wait for a while until the surgical intervention. He favorably lost over 60 kilos for 2.5 years. However, afterwards, he found a job and he changed his lifestyle due to a lot of social activities, such as sometimes he had to go to the bars, sometimes go to the restaurant, to get together with other people. So he frequently attended drinking parties and could not keep promise to get diet and advices. his weight was rapidly increased. After 25 weight was rebounded, we introduced inpatient diet treatment to him again. So it's quite difficult to keep good treatment for the younger age. So, in conclusion, bariatric surgery leads significant short-term weight loss and frequent resolution of obesity-related comorbidities in children and adolescents. Long-term prospective randomized, well-designed studies are necessary to firmly establish the benefits of bariatric surgery in children and adolescents. Thank you for your attention. Thanks so much.
for Dr. Seigo.
Yeah.
Actually, we will have some organization here. Before the allocated time get finished, we will build two bill rings, and 1 minute before that, or at the end of that, we'll have two bill, or 1 minute it will be one bill. Okay. So our next speaker is Dr. Luigi Angriziani from Napoli, Italy. He is a laparoscopic consultant surgeon and bariatric surgeon.
Pointer? What's the pointer? Thank you very much, Dr. Lagdavala. Was a very nice, it's always very nice experience for me coming back to this country that I really love very much, probably because India is very similar to southern Italy, and many features of the Indian city are similar to Naples and many cities in southern Italy. So I have a very I've been saying in my previous trip to India that the southern Italian and Indian are like cousins because of their similarities. And I very much appreciated the topic that I was given. That is one of my favorite topics, the controversy on BMI and BMI guidelines, because I'm totally disappointed to the way we have managed this problem over the last 15 years. I must confess to you that I will go very quickly on the first part of my presentation, which address the story of BMI and diabetes that, as I understand, will be addressed many times this morning and during this meeting. Of course, the story of the NIH guidelines is too old, is definitely need to be updated, but although many people are talking of it, nobody has done very much. And I'd like to report what is the last data I found on the World Health Organization, where it is very clearly stated that also pre-obese people have a risk of chronic disease. And although, as you know, recently, there has been some literature that probably John Dixon and some others will address, where they say that in overweight and class 1 obesity people have a best prognosis in life, long-term prognosis. I think all the Americans keep presenting enormous, large, extended paper saying basically always the same things. Only the guidelines in 2008, the American Association for Endocrinology, Obesity and Surgery, the only new things that addressed is the fact that, as you can, I cannot manage. They only introduced the possibility that you can do surgery with comorbidity like body size, precluding or interfering with employment, and some bone problem. But I think that a significant, very good document, very good action was taken by FDA when it accepted the lab band for low BMI patient. I honestly thought that this would have been opened the way to a lot of institutions and surgeons around the world doing banding in low BMI, in people below 35, but I'm afraid this, I think, has not happened. And probably because the company and the FDA had published the document, but this document was not incorporated by any society or any federation. And of course, the FDA was based on John Dixon and Paul O'Brien basic masterpiece paper, and there was also some press and media communication. But nothing happened, and basically I honestly was very disappointed also by the Diabetes International Federation document, because at the end of the document they say that diabetic people should be operated if they are obese, but this is quite obvious. And when we go back to, they mention in the document that some Asian and some other ethnicity should be considered for low BMI, but at the end of the day, when you say if they are eligible for surgery, you say yes, conditional, and the limit for the indication is quite tough. I don't understand why you should wait to have an uncontrolled diabetes to have an operation. To me, is not acceptable. I will shortly summarize that the entire literature has a very limited number of patients, I'm afraid. This is a very nice review that was published, but the number of patients is limited, although you see the studies are very few, so I would encourage all of us and all of you to publish more on this topic. Again, the conclusion are that, of course, diabetes surgery is a significant step forward for those kind of patients in the longer range. And specific indication, banding is good, and probably bypass and sleeve gastrectomy are also very good. So I will shower, of course, as published, although it mixed the number of patients that were not all below 35. I think from Rome, from Nicola Basso and the group of surgeons I know, each of them, they published a very nice paper that was considered for SORD, is published on SORD, where sleeve gastrectomy alone did a significant benefit to, after 5 years on the treatment of diabetes. This is a very important paper, I think, because it's going really much to question the rule of which is the best operation for BMI lower than 35 in diabetes population. I think that sleeve gastrectomy has a definitive place in this range, and of course mini gastric bypass and ileal interposition also can come out. But the problem is that we need to publish and to prove that these operations are good operations. First, to prove that they are safe. Second, that they are good in controlling diabetes. Now, let's move to the second part of my presentation that to me is my favorite part, because I think that since I started obesity surgery in 1995, I always consider diabetic a very good indication for obesity surgery, and I've always operated everybody with diabetes provided there was BMI over 30. So for me, personally, for my cultural background, whatever has been happening on diabetes surgery over the last 15 years was nothing, because I incorporate this criteria in my educational background since I was 35 years old. This is a very delicate topic. Should we consider people below 35 if they are not diabetic, I mean beyond diabetes? We are talking now of other comorbidity, and this is an area that I would like to address specifically this morning to hear your opinion, because for me it was obvious that if somebody is obese and is class 1 obese and he cannot succeed or she cannot succeed to control his weight or her weight, she needs surgery, and she needs minimal invasive surgery. But this is addressed in very few papers around the world. One of the original paper, it was from Malfobi, and from that point I started really to think that we should investigate more in this area. In fact, after that time, I managed to collect a very large Italian experience on lab band on BMI less than 35. At that time, perhaps Italian surgeons were not scared to operate these people. They were not limited by medical-legal controversy, by ethical committee. But in fact, I think I'd like very much to focus your observation on the fact that the 5-year survival, the 5-year weight maintenance was very good. But very interestingly, if you look at this paper, a minority of the population were diabetic, and if you analyze there were 50% of the population that had at least one comorbidity, but there were 109 patients without any comorbidity, so people that are totally considered these days off-label in recent international guidelines and position statement. Again, I think on that ideas, John Dixon and Paul O'Brien published a fantastic prospective randomized trial proving the benefit of the lab band in that population, and Christine Wren and George Fielding that basically is a branch of the Australian community transferred to New York, and they proved also a very nice set of data concluding that we definitely need to modify this position statement and these guidelines. Over my presidency of the Italian Society, I'm sorry these are in Italian, but the message is that I try to modify, and we have been fighting in the society. I was president at that time with a lot of old-fashioned physician and surgeon, but we managed to go to convince the Italian community that also hypertension, esophageal reflux, and bone arthropathy could be an indication for bariatric surgery in low BMI patients. And recently, we have published on the fact that we have 7 years weight follow-up of a patient with, this is my own series, where, as you can see, 50% again of this population have no comorbidity at all. So these are people that have no declared clinical medical comorbidity that I operate, and they did very well over a long term. I think in the literature, I recognize this paper from Walter Porris, I think very emphatic, very precise, very determined, to conclude that, again, on diabetes, we need to change the guidelines. And finally, he showed that the risk of developing hypertension and cardiovascular disease is different for different ethnicity. And he showed a very meticulous table with relative risk for each kind of comorbidity in people below 35. This is a nice conclusion of that paper from Walter Porris, where basically he asked himself and all of us as a surgical community, why we should not apply in bariatric surgery and diabetes surgery the normal feeling, the normal sense of clinical use of surgery to treat medical disease. In the last few months, based on this, let's say, 15 years interest in trying to modify the indication for bariatric and metabolic surgery, I managed, under the presidentship of Professor Chobey and the honorary presidentship of Nicola Scopinaro, who is very favorable to this document, to this activity, we have included a number of surgeons to work very solidly on this topic and to basically to have a formal official document, because when you talk of guidelines, you may have national guidelines, you may have chapter guidelines, and you may have worldwide guidelines. I have been told, and I agree, that there is a hierarchy of guidelines. So at the end, the IFSO, that is the World Society, should incorporate all the guidelines and make one document that at this time is a position statement. I hope with the help of you and whoever feel that this could be able and could be productive in doing this document, please contact the secretary or myself or whoever is in this activity and this position statement document. Thank you very much.
Thanks, Dr. Luigi. Our next speaker is Dr. Suthip. He is a consultant laparoscopic and bariatric surgery from Thailand, Bangkok. Please.
Thank you, Mr. Chairman. I would like to thank Murphy and also our partner for the invitation. This is a very beautiful place for meeting. My topic today is a BMI specific guideline for type 2 diabetes. Are we correct, or do we need more? I think my topics has been already covered by Dr. Angisani. So I'm going to go in brief about BMI, and also today and tomorrow we're going to mention about BMI. Diabetes has been known that because of the function or the availability of the insulins, it could be by fat cell or it could be production of glucose. So there are many pathogenesis of the diseases. So us, as a bariatric surgeon, also metabolic surgeon, we've seen the result of the improvement of diabetes. So back again about BMI. So here the palace, so I bring you all back to the history, has been proposed by Adolphe Quetelet. He's a Belgian mathematician and also astronomer. He's a statistician. So he introduced this formula in 1832. Been popularized by Ansel Key. He's from Minnesota. He used the same formula to find the normal man. So this is to find normal man. But finally we use for other purpose. But there are many limitations in the BMI. It doesn't reflect proportion of body weight that consists of fat. Absolutely. And also, more than that, it doesn't demonstrate the fat distribution. It's not the whole fat in the body caused the problem. So this is the major limitation. It is started in European ethnicity. So we are other part of European. Is this true or is not true? It's been proved that we need to adjust. And also it often underestimate the health risks for the population. It's shown by this beautiful graph. You can see, so in the line that is the BMI, you can see that actually it has a trend to be little between the BMI and the percent of the fat. But for sportmen here, you can see that the BMI, it supports that kind to be more fat, but that weight consists of the muscle, so this is the limitation. And also in our group of the patient who have higher BMI, it's prone to have more fat in the body. So this is the limitation. But it is good to use BMI, at least for BMI and mortality. There are many papers, many reviews to show that there is correlation between BMI, mortality. For example, this is from Lancet. You can see that even low BMI, very low, thin, or super obese, it should be increasing the mortality. Again, we're trying to keep a question: is this BMI is good for the guideline? Unfortunately, I have. If you look into the schedule, you can see we have experts in, especially deep in the field of metabolic surgery. I'm going to go touch a little for some result because we need to make a relevance between BMI and results of the diabetes treatment. So this is meta-analysis, Buchon. You can see that. This is from obese. BMI 40 to 50. This is obese. This is our patient. So you can see the remission rate is very good. The BPDDS, no question. The remission rate was 95%, following by lung wide bypass and at times gastroplasty, and also lung wide gastric bypass at 56. So it's good. The remission rate is very high. It was about that is a meta-analysis. This is a randomized controlled trial. Megon, you can see that the same. BPD have the remission rate of 95. Lung gastric bypass have 75%. Comparing to medical treatment, there is no remission at all. This is the strong evidence. We come with the BMI, with the weight, and we go lower and lower. You can see by this one. This is the randomized controlled trial. It's come out last month by a group, Makudin from Minnesota. You can see that BMI is lower to 30 to 40. with diabetes more than 6 months, C-peptide of 1, and also 1-year follow-up. You can see that the number here, it's decreasing. It's about 50% for Lung-wide bypass, and the intensive medical treatment is about 20%. Combination of those who have lower BMI, lower than 35, you can see that half of them. So that would be part of the result, but this is also 1-year follow-up. Again, Fuchara, yeah, this is the paper. You can see BMI of 27 to 43, but here BMI less than 35 is about one third of the group of the patient. Again, the result of the remission is 42% for lung-wide bypass and 37% for sleeve gastrectomy. With the medical treatment, it's about 12%. We try to keep low and very low. This is Professor Lee randomized control trial. You can see that. Lung-wide bypass, the BMI is 25 to 35. You can see that. 93% of remission from lung-wide bypass. This is 1-year follow-up. And for the sleeves, it's about 47%. So just go down to 25 at the lower limit for the BMI. So the all information, you can see that for higher BMI, the result is very good. And also, we can have more and more discussion from the debate after this. For non-obese diabetes, it is similar. It's some different. It could be something that behind. You can see that for obese and non-obese is different in the natural history of the treatment of diabetes. Again, we're going to discuss about the predicting factor for those who will be beneficial from the surgery. So this is from John Dixon. You can see that BMI is part of it. There are 3 factors: duration of diabetes, C-peptide, and also the BMI more than 35. Talking about weight, so and the response to the treatment. So we may need to discuss a little. We have this discussion later on about mechanism. So it could be weight loss or non-weight loss. Weight loss, it's about restrictive. But what we evidence is that even the patient doesn't have much weight loss, but they have beneficial from the glycemic control. So that could be the lower and upper. We have in the meeting the discussion in detail. This is why it happened very quickly after the operation. This is the weight loss factor. You can see even by the medical non-operative treatment. This is the study with the very low calorie, 600 a day. They follow for 8 months. You can follow this. This is the baseline, the percentage, the percent of baseline. You can see 100% at the beginning. After 8 weeks, you can see about 15% of weight or BMI reducing. But the hepatic fat, the triglyceride, you can see is almost 70% reducing. So that could cause the improvement after the restriction. So maybe because of the normalization of beta cells could be associated with the liver fat. We also have the information that non-weight loss factors, but we have information about ghrelin. We're going to discuss more in detail, but the comment to that is that we don't have long-term follow-up. We don't have the physiologic experiment that it related directly to the level, not only the plasma level that it has shown change. Fat is a problem, especially for visceral or intra-abdominal fat. But BMIs have many limitation, but this is non-expensive, very easy to calculate. That's why it's still popular. What else that we can do? We can do the old technique by water displacement technique, and then we use the calculation to estimate percentage of fat. We cannot do any exactly fat, especially for visceral fat. Skin fold, just outside, or we can calculate for BMI. You can see that we don't have any measurement to accurately measure the percentage of fat. If BMI is not, what else that we could do? This is the physics thing. So it says power by 2, this is BMI, may not correlate with some factor, so they put in power of 3. That's called ponderal index, but there is no information on that. What should we do by body volume? Anything else that could be replace the BMI? So we still need more. This is the conclusion, my conclusion. And BMI specific guideline, are we correct? Absolutely, I think we can say that we are not wrong. We good, especially for BMI more than 35. What we need more, especially for low BMI, we need more. Yes, I'm totally agree that we need more information. Why we need more? Not only us as a surgeon or our patient, but we need cooperation. We work in team.